It was kind of funny talking with all the speakers earlier today. They were all really excited because they were like, "Yeah, I'm going to tweet and send LinkedIn posts out because I've got the best opening act in healthcare, right? Zubin's going to pave my way, and it's going to make me big, and no better way to kind of kick off my speech." I think they're probably second guessing that strategy at this point because the bar's, it's not low. It's not low. So we're going to keep moving on. We're going to shift gears here. The next speaker is a very unique guy. And a lot of our one of the phenomena in direct primary care is a belief in a strategy to help support and transform the healthcare system working with employers. Employers provide healthcare benefits to the majority of Americans. Primary care has been decimated in this country. Employers are just starting to wake up to recognize that having really strong primary care at the foundation of their health plan or self-insured plan is probably the most effective and transformative thing they could do first to change the game. Direct primary care organizations and doctors are recognizing this. They're talking to employers about this concept. But there's this other stakeholder in the healthcare system called the benefit broker, benefit consultant. I'll get corrected on the language. That helps work with employers, as you guys all know, to help understand what they should be doing. And we have direct primary care doctors all across the country every day call us, and they say, "Mike, I had an incredible conversation with several employers today. They totally get it." And then they refer me to their benefit broker, guy or gal, and the conversation doesn't seem to go anywhere. They don't really get it, and they don't really understand why. And they say, "Mike, can you guys please connect us? Is there anybody out there that has employer relationships that are these benefit consultant guys that get it and that can help them understand how transformative this can be?" Because they're so important in that employer relationship. And the fact of the matter is that that's a whole industry that actually needs to transform like primary care and direct care needs to transform. But the good news is that it is transforming. And there's a small but growing group of very influential and thought-leading benefit consultants that are totally changing and upending their industry to be able to help employers and align incentives and do great things. And one of the thought leaders is David Contorno, who's our next speaker, and he's here to teach you about some of that topic.
So I got 15 minutes here, and I'm going to probably not go much by the slides because I realize that I'm in a room full of people that I'm not normally in a room with. And that is a room full of people that have already led a change. I am usually in a room full of people that are fighting the change to the extent that there are drag marks in the concrete on the sidewalk out front. So I want to tell you, I've been doing insurance all my life. My first job was in the insurance industry at 14 years old. I specifically started in benefits at 17 years old. And I'm now 41. So I've been doing this for 24 years. And for the first 17 years or so of my career, I was the traditional broker. And I want to share a little bit about what that means and why some of you constantly scratch your head as to why the system continues to work this way. Because in my view, the payer of healthcare is not the carriers. If anybody calls Blue Cross the payer in my presence, I will chastise you. The payer of healthcare in my world is the employer and the employees. And I think it's important to understand that because we as a broker, I don't know of another professional that an employer brings in that has the opportunity to touch so much of a business. We touch financially in a huge way. Just so you know, healthcare is number 2, 3, 4, maybe 5 on a company P&L. It's certainly in the same level on every employee's personal P&L. And of course, the plans that we set up and the type of care that we help finance and deliver also affects the entire company and their families physically. So there's a huge responsibility here that, quite frankly, I think that we're missing. So why is the system like this from our perspective? Well, we're paid very well to keep our mouths shut. We have traditionally worked on a commission basis. So as insurance premiums went up, so too did our revenue. And I'll tell you this story. So like most brokers, I was way overpaid for the amount of work that I did for my clients. And because of that, I drive a nice car. I have a driver on staff so I can get work done. And I made the mistake of pulling up in my nice car with my driver to a lumber manufacturer in rural North Carolina. And not only that, but I was talk about not reading a situation. I was going to try and save an account that one of my salespeople had brought from a really rich PPO plan to a very lean HMO plan. And I go in to save the money that we were making on this, and I walk into a hornet's nest of employees with stacks of bills and things that weren't being covered. But I wanted to get to the root cause of the problem, so I'd start looking through the bills and asking questions, and this one guy comes in, rough and tumble guy, maybe in his mid-50s, and he sits down at the head of the table, doesn't say a word. And when I'm done with the two women, I turn to him and say, "Sir, how can I help you?" And he says, "Don't blow smoke up my ass." I said, "Excuse me?" He said, "Don't blow smoke up my ass. I saw you pull in here in your six-figure car with your driver. Meanwhile, my wife is at home writhing in pain because we can no longer afford the multiple sclerosis medication that we were getting that allowed her to function." And I left that meeting feeling like I had literally taken money out of that family's pocket and put it into my own. And I came away from that realizing that I have to do one of two things. I either have to get paid less money, or I have to provide more value. I chose option B because I like my car and my driver. So I started to realize that everyone talks about health insurance being so expensive because health care is expensive. Everyone says that. The carriers say it, everybody. So what I realized was nobody in my industry understood how health care is paid for. They barely knew what a CPT code was, let alone a DRG, an RVU, a revenue cycle manager, all the acronyms, names, and people and consultants that get paid to extract as much value out of the healthcare system as possible. And I recognized that if I want to change and provide more value, and the cause of me not doing that is the cost of care, whether it's unit cost or quantity consumed or a combination of the two, I had to figure out a different way to pay for care. Because ultimately, with Z-Dog talking, I mean, that's a lot of what every doctor's miserable life is in the fee-for-service world. It's all about generating that revenue. Every note, every code, every time that a patient calls up with a urinary tract infection and you know you can prescribe an antibiotic over the phone, but you can't because you don't get paid if you don't get them inside your office. Every encounter like that. And then the massive amount of unnecessary care and excessive care, because the reality is that in every economic model that I know of, the consumer is the one to protect themselves against abuse, fraud, and waste. They're the ones who determine value. And in my world, value is where quality and cost intersect. And my definition of value could be different than Jamie's definition of value, but we get the opportunity to assess that. And so what's missing in healthcare, and I think this is pretty obvious, is the consumer of the services, the patient, and the payer of the services, the employer in my world, are two separate entities. As a matter of fact, most people view the carrier as the payer. And so everyone feels it's okay to take advantage of the payer. The hospitals feel it's okay. Many doctors feel it's okay. The brokers feel it's okay. But even the patients feel it's okay. I mean, I know people that get a bill from a hospital stay and show that it was $220,000. Their insurance covered all or most of it, and they laugh. They laugh. Because to them, it's like, haha, got one over on the insurance company. So we are paid very well to keep our eyes shut. As a matter of fact, just the other day, my client forced me to get numbers from Blue Cross and Blue Shield for them, and I did. And about 10 minutes after they send me their numbers, assuring me that they're competitive, they send me the bonus structure tied to me writing that group. And this was a group of 80 employees, of home builder, and the bonus on top of the regular commission would have been $25,000. So to think that this is not profitable for the insurance companies is absurd. They give huge amounts of money for us to keep our eyes shut. And at the end of the day, I asked brokers and my peers, I said, whoever is cutting you that check every month, That's who you work for. So don't purport to work for the client when they're not paying you. If the carrier's paying you, you work for them. So I started down this other path. And I realized that when it comes to employer-sponsored healthcare, there's only 3 stakeholders I care about. Number 1, we have the payer, which is you, Mr. Employer. Number 2, we have the patient, which is your employee. And number 3, we have the provider, which is their doctor. I don't care about anything else. Everything else is just noise. And we want to minimize the noise as much as possible. So what we've done is we've started to develop a methodology. Now, you got to understand that employers are as addicted to Blue Cross and Blue Shield and United and Cigna and Aetna as hospitals are. I actually got a little bit of an inside look into how addicted the hospitals are recently. An ER bill for my 6-year-old son. We thought he had an appendicitis, so it was late on a Tuesday night, and we go to urgent care right before they close, trying to do the right thing. Doctor at urgent care doesn't even look at him and says, we're calling an ambulance, and he's going to Novant. I live in Charlotte, North Carolina. And I said, why an ambulance and why Novant? He said, an ambulance because he's clearly in pain, and Novant because it's the only place that accepts pediatrics for surgery, and if he needs his appendix removed, that's where he's going to have to wind up anyway. So I said, you're not calling an ambulance. I'll take him to Novant myself. So I take him to Novant. We wait an hour before we get to see a doctor, and the doctor says, within 5 seconds, that's not an appendicitis. I said, how do you know? He goes, it's presenting on the wrong side of the body. That would have been good information to have from that urgent care doctor an hour before that. Anyway, it wound up being constipation. They give him an enema, and he's fine 30 minutes later. So a few weeks later, I get the bill, $3,900. I asked for an itemized bill, being a little smarter than the average healthcare consumer. And the itemized bill, the biggest charge on there said LVL4 ED. I'm like, level 4 emergency department. So I Google that, and I find the American College of Emergency Room Physicians clinical coding guidelines. I presume that to be what people follow, and it says there are 5 levels of emergency room department coding. It has certain pathology that must exist for each level, 5 being the worst. Mine's coded level 4. The pathology that needed to be there just didn't exist in constipation. Maybe appendicitis, but certainly not constipation. So I call the hospital up and I said, guys, you miscoded this. And they send it back for clinical review. They promise to call me back. They don't. I call them back and they said, yeah, we reviewed it and we denied it. And I go, listen, I get that you don't want to be paid less money. I get that. However, this is about what's right. So they send it back to clinical review. They deny it again. Well, power of social media. So I have a pretty strong following on LinkedIn, and I posted up this story, and I tagged the CEO of Novant. I think they're about a $6 billion health system. And all of a sudden, people start sharing, liking, commenting on it across the country. And every time they do that, because I tagged the CEO, he gets a notification. So he eventually responds. And he says, David, I'm going to have someone reach out to you. So I get this woman who's head of customer service reach out to me a couple days later, and she says, I tell her the story, and she says, well, we're going to refund you the difference between level 4 and level 1. We're calling it a customer service refund. But I will find out for you what the coding guidelines are, and I will share them with you. And if we were wrong in coding it, we'll admit that. I said, okay. So a few days later, I get an email from her, and it basically says, we don't follow any national guidelines. We just basically make it up ourselves. And I go, Kim, this is very different than what you told me. You specifically said there are national guidelines that you follow. Therefore, you're not setting it yourself, and this is completely opposite that. A couple days later, I get a very lengthy email from a different woman who claims to be the head of emergency department coding for the entire system. And she gives this very lengthy email. The one word that stuck out was, we use a software for our emergency room department called Optum 360. I said, Optum 360, huh? So you rely on the carriers as well, just as much as the employers are addicted to the carriers. The fee-for-service doctors, when we blow up a plan and rebuild it, and we put in a plan with no network, we use something called reference-based pricing as a way to set the pricing. And that's typically a markup of Medicare. So for most doctors that are still fee-for-service, we'll give them 130 or 140% of Medicare, which is typically 5 or 10% more than the PPO pricing winds up being in most PPOs. But what's funny is we have these patients who walk into their doctor with no logo on their ID card, and their doctor's office says, we don't take that plan. So when we first bring it, I have to calm the panic down, and I call the doctor's office, and I said, hey, you turned away one of my clients. They said, you don't take their plan. And they go, yeah, we don't take their plan. I go, well, that may be true. There's 2 requirements to take the plan. Number 1, the doctor must be a licensed physician. Is your doctor licensed? Yeah. Okay, great. Number 2, you must accept money as a form of payment. Do you accept money in your office? Well, yeah. Okay, great. You take our plan. It's so foreign to them to not submit a claim on a HCFA form through a payer ID and be told what they can be paid, what they can't be paid. Now, there's a doctor in this audience. I will not bring his name up. And I said, I want to see what you sign when you agree to be in network. I want to see it. And he says, I'll send it to you. Yeah, no problem. A week or 2 goes by. Haven't gotten it, so I send him an email reminding him. And he's like, okay, I got to be honest with you. I'm going to send it to you. But there's not a single doctor in this country that has ever read one of those contracts. Because there's nothing we can do about it anyway. So I read through that contract, and I am not a lawyer, but I would suggest that any of you that have previously signed these look through it, because especially if you're looking at it through a new lens, it's a very interesting thing. But I got about 90 seconds left. So what I want to say, guys, is I am such a firm believer in this movement that proper primary care needs to be the underpinning of our delivery and financing system, so much to the point that we're starting to build plans for our clients in which going through the direct primary care office is a requirement for anything to be covered, except emergency. So when I look at friends like Alex Lickerman, who's here in the audience, he feels that it's his responsibility to not only prevent that patient from leaving his office, except when truly necessary, but more importantly, to be that shepherd, that Sherpa, for that patient. Because something occurred to me not that long ago. Imagine if you have a 15 or 16-year-old child who's getting ready to learn to drive, and you decide the most effective way to teach them to drive is to spend 99% of the time educating them on their provisions of their Geico policy, and only 1% of the time on how to safely operate a vehicle. That's pretty backwards, but yet that's what HR and brokers and employers do. They spend 99% of the time teaching employees about the provisions of their health insurance policy, and 0 time how to be a good patient, how to be a good healthcare consumer. So you doctors in this room are the front line of that movement. You should be providing 80% of care, whereas we see, at least in the dollars, that you're doing 3% of care or 5% of care. So we put a huge investment with our clients in direct primary care. We typically increase that spend by 50, even 100%. And what we see, as many of you guys already know, is a huge reduction in outpatient, inpatient, and specialty medications. I mean, huge. About a 40% or 50% reduction in that, and that's 60% of spend for most employers. So I want to thank you guys, because until I met some of the people in this room, I was very adversarial against doctors. I actually blamed a lot of you guys for abusing the system, and that's why the carriers were putting these countermeasures in place. That's what I thought 6 or 7 years ago. And then I started to see, well, doctors are now the #1 suicide rate of any profession in the country, that you guys are dealing with everything that Z-Dog showed on that screen every day, and that you guys are part of a system that I too was a part of that incentivizes all the wrong behavior. So I just want to say thank you to everyone in here for caring about the patient above and beyond everything, for really doing what you guys went to medical school for. Alex says all the time that since he went direct primary care, he is reinvigorated at the concept of practicing medicine, and that warms my heart. There should be a strong patient-provider relationship, something that just doesn't exist. I'll leave you with this. In ancient Chinese medicine, doctors were only paid when their patients were well. And the second that their patient became sick, they stopped receiving money for that patient. It was also frowned upon to fix things surgically. It was actually seen as a failing of the doctor. I know that's a little extreme, but isn't that what we're trying to do? We're trying to incentivize proper care, keeping people healthy, getting them healthy, and holding them accountable to that. So thank you all for all you do. If I can answer any questions on how we design plans and how we finance that, how we pay you guys through a plan, how we incentivize proper behavior, I'll be happy to speak anytime. But enjoy the rest of the conference, and thank you for having me.